Today's webinar is about what to expect for large B-cell lymphoma treatments. We chose today's topic because it's important for patients to understand the treatment options they have available at all stages of their cancer journey. We are very excited to have Dr. Hunter share his expertise on this topic with us today. Dr. Brad Hunter is an associate professor of research at Intermountain Health, where he directs the Immune Effector Cell Therapy program, as well as the Oncology Research program. Since he began leading the program in 2019, Intermountain has rapidly expanded its standard of care and clinical trial footprint. He serves on multiple national committees related to CAR T-cell therapy and has written national guidelines for the delivery of cancer care. And with that, I will turn it over to Dr. Hunter for his presentation.
Hey, everybody, thanks for joining. Let me just see if I can share my screen correctly, and then I can start the slideshow. Just one sec here. Okay. I might have to do this in two parts. Let's see if I do. Maybe if I do this might work. Okay. So if I hit. Okay. Do you see my slides?
Yep, that looks perfect.
Great. Okay. So thanks everyone for joining. My name is Brad Hunter. I am a stem cell therapist, which means I provide patients with bone marrow transplants and also advanced cellular therapies, really using the immune system to fight cancer. I just take care of patients who have blood cancer, so leukemia, lymphoma, multiple myeloma, although now there are cellular therapies that are available for patients with melanoma, and then also a special immune therapy for small cell lung cancer. So I'm doing a little bit in the solid tumor space as well. Additionally, I help run a clinic that does what are called phase 1 research trials. So those are the very earliest research trials of a new therapy, where they are kind of first in human trials and are essential for both being able to demonstrate safety and then also bring the most promising new therapies to the clinic as soon as possible. These are my disclosures, just companies that I have done work for, either on a consulting basis or speaking of research. So, today we're going to talk about the treatment of diffuse large B-cell lymphoma and what we call the first line, second line, and third line. So first line would be the very first treatment you receive. Second line is that second treatment, and then third line would be after the second treatment. So going to that point. So for the front line or first line therapy, there are really the mainstay for a long, long time has been a regimen called R-CHOP. That is a drug called rituximab that is a special antibody that attaches to B lymphocytes and kills them. And then 4 other drugs, 3 of those are chemotherapies, cyclophosphamide, doxorubicin, which used to be called hydroxyadriamycin, and that was H, and then O, which used to be called oncovorin, is now called vincristine, and then prednisone, which is steroids. There are other cocktails that are similar to that, such as a dose-adjusted R-EPOCH, which is up there for patients who have double or triple hit lymphoma, and then lastly, polatuzumab with rituximab and cyclophosphamide, doxorubicin, and prednisone, or pola-R-CHP, for patients who have a risk score of 2 or higher on what's called the International Prognostic Index. I'm going to go over a little bit of slides of why we've started to use pola-R-CHP, but those are the mainstays. And so for a long time, for 30 plus years, there are what we call a graveyard of studies trying to beat R-CHOP. We can cure anywhere between 55 to 75% of patients, depending on their risk stratification within diffuse large B-cell lymphoma with R-CHOP, which is wonderful. Not very many cancers are curable always on the very first go round, and there are wonderful results with R-CHOP, but it's nowhere near sufficient. Obviously, we want to get to a place where every patient with the very first treatment is able to be cured. So we've been trying to improve upon it for 30 years, and it's been a multitude of failures of being able to be better than R-CHOP. until very recently. So I want to talk about two specific studies, which are indicative of others that are ongoing, but we don't have time to go over every single trial and new emerging therapy. So just going to tackle a couple today. So this first one is called the POLARIX trial, which led to the approval of polatuzumab in combination with R-CHP for the treatment of diffuse large B-cell lymphoma as in the frontline setting. So the way that this trial was laid out is patients who had at least intermediate risk diffuse large B-cell lymphoma. So they had an IPI score of 2 to 5. And an IPI score is calculated by some lab values if they are higher risk, the stage of cancer, the patient's age, and then what is called a performance status, which just means how functional is somebody. Is the cancer not affecting their life? Is it mildly affecting them, or is it causing them to not be able to be out of bed for a big chunk of the day or out of a chair, et cetera? So for patients who had previously untreated diffuse large B-cell lymphoma and were aged in this trial between the ages of 18 and 80, they were treated with, they were randomized. So half of them received standard R-CHOP, and the other group received Pola-R-CHP. And then they were, those in the R-CHOP, they did receive a placebo that was not really polatuzumab, but looked like it could be. And then those on the treatment arm received the polatuzumab drug with R-CHP. They were treated for 6 cycles of the therapy, and then they actually received 2 additional treatments of rituximab alone. And the main purpose of the study was to determine progression-free survival. So that means that you are in, you go into remission and you stay in remission. So that was what they were trying to see. Is there a difference between these 2 treatments when it comes to progression-free survival? Okay, so they were followed for just between around 5 years on average for their survival after the treatments had been administered. In this trial, this is the progression-free survival curves. There was a statistically significant benefit of receiving the polatuzumab R-CHP as opposed to R-CHOP. So this is the first trial in 30 years that was able to beat R-CHOP. And when you look at 5 years out, an additional 5% of patients were still in remission. So 65% of patients were in remission that received Pola-R-CHP versus 59% of patients who received R-CHOP alone. So, it showed impressive results, and this has now become a standard of care for many patients in the frontline setting. The main side effect that is unique to polatuzumab is neuropathy in the fingers and toes, mostly we call peripheral neuropathy, which is also the main adverse side effect of vincristine or oncovorin, the O in R-CHOP. And so that's why it is not in the regimen when you combine it with polatuzumab, so to minimize long-term neuropathy. There's another trial that is ongoing with a drug called epcoritamab that is a bispecific antibody. I will get to what is a bispecific antibody a little bit later in the talk. But this trial was looking at combining a bispecific antibody, which is an immune therapy, which brings an immune cell together with a cancer cell and helps the immune cell to kill that cancer cell, combining that with R-CHOP to see if that could also improve upon response rates for diffuse large B-cell lymphoma in the frontline setting. In this trial, patients were had to be newly diagnosed with diffuse large B-cell lymphoma. They could have several different subtypes, including a more aggressive version of follicular lymphoma, which is traditionally a more slow-growing or indolent lymphoma, but when it becomes 3B, it's more aggressive. These were a little bit higher risk, so they had to have a risk score of 3 or higher, whereas in the POLARIX trial, they had to be 2 or higher. The patients were given standard R-CHOP every 3 weeks, and then they were also had the ability to be given the epcoritamab drug, which was given weekly for 12 weeks, and then every 3 weeks for the last 6 weeks of combination with R-CHOP therapy. And then after that, to complete 1 year of therapy, after the R-CHOP was done, it was continued for an additional not quite 6 treatments, but for an additional monthly treatment until you'd reached a year on therapy. So this didn't format very well. I apologize. The primary endpoint in this trial was to look at the overall response rate and then to see, how deep those responses were and how long they lasted. So whereas the other trial had 5 years of follow-up, this has a little over 2 years of follow-up. And patients, like I said, were relatively high risk in terms of their stratification of their disease. So they had higher stage disease and a more aggressive disease. A big chunk of them had bulky disease, which means they had a mass, at least one mass that was 10 centimeters or greater. 1/5 of them had the kind of the dreaded double or triple hit lymphoma. What is really impressive is the response rate. So you can see that the response rate in almost all groups was 100%. Every patient achieved some sort of remission. A complete remission means the PET scan or the CT scans were normal and did not show any signs of disease. And so in over 80% of patients and close in some subgroups to 90%, they had normal looking PET CT scans after therapy. Almost every patient received the full allotment of epcoritamab, at least half of them did. And then, most of them got full dose R-CHOP as well. So they were getting full therapy, and the results thus far have been really impressive in the first 46 patients. This is looking at the progression-free survival. So if you remember, we were seeing, 65% at 5 years in the Polarix trial. And let's go back to that slide really quick for reference. At the 2 years update, it was a 76% of patients, almost 77% of patients were still in remission. And with this, it's 83% of patients are still in remission. So really exciting results. Still not where we need to be, which is a straight line where we see that every patient is responding, but really we are making inroads and improvements in frontline lymphoma that we have been trying to do for decades. And it's exciting that we're actually in a place with new therapies that we're improving upon, where we had been for a long time. So in moving from the front line into the second line, we kind of split patients into 2 groups. Patients who are relapsing less than 1 year from their initial treatment, which includes patients who do not respond to the first therapy, and then patients who relapse more than 1 year from their initial treatment. For patients who relapse at more than 1 year from their initial treatment, the goal is to help that patient get to a bone marrow transplant, and that's a transplant from themselves. That's called an autologous stem cell transplant. It's not really a transplant because it's your own cells. It's a bit of a misnomer. Perhaps a better term is called high-dose chemotherapy with stem cell rescue. You are trying to give one last massive dose of chemotherapy to rid the body of any microscopic cancer that may be left in the idea that you can cure the patient. That requires chemotherapy before the transplant, and the transplant's brutal. It is not a very fun process to go through, and takes many months to kind of get back to where you were pre-treatment in terms of how well you're feeling. For patients who relapse at less than 1 year of transplant, they are able to receive CAR T-cell therapy, and we'll look at some of the reasons for that and how it beat transplant in head-to-head trials and became the standard of care. Other options that do not have randomized controlled trial data against transplant but exist in the second line are to use bispecific antibodies either by themselves or with chemotherapy, or to use different chemotherapies or immunotherapies as well if a patient is not a candidate for either CAR T-cell therapy or a stem cell transplant. And so to try to kind of give an idea of what a CAR T-cell is, which is called a chimeric antigen receptor T-cell, there's a great video from City of Hope that I'm going to just link to the YouTube video and let you watch it briefly, and then we can talk about it a little bit further.
When it comes to fighting cancer, the most important battle happens in the immune system. And leading this fight are T-cells, the soldiers of the immune system. When a cancer cell circulates in the body, T cells are supposed to find signs on its surface indicating it's abnormal, then latch on and destroy it. But cancer cells are masters of disguise. They can change in ways that trick T cells into not recognizing them. CAR T cell therapy restores a T cell's ability to recognize and destroy cancer. To do this, first T cells are taken from the patient's blood and genetically modified so they can attack and kill cancer cells. The modified cells are then grown to large numbers outside the body and eventually put back into the patient. Once they are inside the patient's body, the re-engineered T cells continue multiplying and patrolling the body to destroy cancer cells. The hope that this will give the patient's immune system the advantage against the cancer. CAR T cell therapy.
Okay, so the idea behind CAR T cell therapy is that you are trying to teach the body's own immune system how to recognize cancer cells and then kill them. And so you take the cells out of the body. So you undergo a process that's called leukapheresis, where you are pulling the white blood cells out. You are then separating out just the T lymphocytes, which is a subset of cells and white blood cells in the body. You can think of them kind of like army soldiers. So think of it like a traditional, like old school army soldier with a bayonet, and they will stab a hole into a cell, and then that cell, it's a blood and guts. If the inside of the cell goes outside and the cell dies, that's the way that they function. And so you're teaching those cells how to create an antenna that will help them to attach to cancer cells and then kill them. So you separate out those T lymphocytes. So the patient's on a machine for a couple of hours to look just a standard blood donation machine that's able to separate out the white blood cells. The cells are then shipped off to a manufacturing facility where they are separated out to get just the T cells. Then they're activated so that they're ready to take up DNA. And then via a virus, which is hollowed out, it's a virus that's not infectious, but viruses deliver their own DNA into our cells, and then we copy the viruses for those and then make new ones, and the virus can go infect other cells. So a virus can be turned into basically a bus. So you have that bus, and the passenger on the bus is the instruction manual for how to make one of these antennas. So the cell sees the DNA, the cell says, all right, I know what to do with that. It's like getting an instruction manual from IKEA. You kind of see what you need to do. So it's able to look through and then make that antenna, and then sticks it on the outside of the cell. And then those cells are expanded. They're allowed to copy themselves and to be made into a large population of T cells. They are tested to make sure that they will attach to the cancer cells, that when they do so, they can kill them, and then also call in the rest of the immune system cavalry to attack those cancer cells. If they pass all those tests, then they get cap and gown, they graduate, and they are able to come back they're shipped back to the patient, and then they are infused as an IV infusion. And then they will go in and start to continue to copy themselves and become a bigger population and start killing cancer cells. It's really an exciting therapy. And then within the patient, they now have a living drug. So they don't need repeated infusions, and they don't need to, at that point, it's there. And even after the CAR T cells have gone and done a lot of killing of cancer cells, they can still remain in the body and conduct ongoing surveillance in case little cancer pockets are able to arise. They're able to go in and help eliminate those cells. This is like what a CAR T cell, like what the antenna looks like. It's gone through many iterations. The first one on the left is called the first generation CAR T cell. Basically, that one's just a little antenna that can kind of attach. And then the second one looks more like an antibody, and it functions how an antibody does. And it just has a basic little signaler inside the cell that says, okay, attack. Those first generation CAR T cells we knew could kill cancer cells, but they didn't stick around very long, and they didn't really expand into a large population. So the second generation of CAR T cells included what's called a co-stimulatory domain, and that helped to further ramp up the cell so it could be activated and then persist and maybe stick around longer. We now have third and fourth generation CAR T cells that have maybe multiple co-stimulatory domains to even try to better amplify the signal. Additionally, they can even secrete their own immune signalers to kind of help boost the CAR T cells. In fact, today in the New England Journal of Medicine, I should have thrown up a slide, but was published a series of patients that were treated with a new CAR T cell therapy that does just that. It secretes, once it attaches, it secretes its own activators. And so it can stick around longer. And even patients who have had a CAR T cell therapy before and failed it, it can still work really well in them. It's super exciting where CAR T cell therapy is going. However, with these CAR T cells comes some unique toxicities. So while patients may not lose their hair or have a ton of nausea, vomiting, there are other things that happen because you are activating the immune system. Some of those CAR T cell toxicities include what's called cytokine release syndrome. Cytokines are the names, the name that we've given to the signaling molecules in the immune system. Cytokine is Greek for attract cells. Doctors try to sound smarter than they really are sometimes, so we use Latin and Greek, but really, in Greek, they know it just means attract cells. And so these cytokines are released, so you're activating the immune system, and that can make your body think and feel like it does at other times when your immune system is activated, like when you have an infection. Patients can have fevers, chills, shortness of breath. They can feel lightheaded. Just think how you feel when you've had a bad bout of the flu. That's what can happen to patients. Thankfully, there are very good antidotes that can calm the immune system down in a way that helps to minimize the side effects, but in a way that does not affect the cell's ability to function as an ongoing cancer killer. There are special antibodies that block some of the signaling. One of them is called tocilizumab. We can use steroids. We can use other drugs that were used to treat autoimmune diseases. One's called anakinra. It can cross the blood-brain barrier and help to kind of stabilize things even in the brain if the signaling molecules get up there. It can progress to a really hyperinflammatory state called HLH. We won't touch on that right now, but usually with treating with some of these, what we call anti-cytokine therapies, patients are able to kind of have that calm down and still do well. There is what's called neurologic toxicity, or a syndrome called ICANS, which stands for immune cell associated neurotoxicity syndrome. But that is basically the same idea of having your body feel like it has the flu. Those signaling molecules work their way into the central nervous system, and now the patient's brain thinks that it has a brain infection. So people tend to feel confused. It's nearly universally reversible with steroids, a drug called anakinra that again can cross the blood-brain barriers, and an autoimmune drug that works really well for this sort of thing. Then so patients can kind of become confused for a few days or even a few weeks, but as the inflammation tamps down, the patients tend to feel better, and the confusion resolves. Because we are giving treatments that kill B lymphocytes, like for diffuse large B-cell lymphoma, patients can have infections. We monitor them closely and put them on prophylactic antivirals and antibacterials, even after the CAR T cell therapy is done. We oftentimes can stay on them for 6 months or longer. There are some patients who can have long-term low blood counts for at least several months. So we will sometimes need to check a bone marrow biopsy, make sure things look okay, but most patients don't have that. But if it does, then we have a plan to monitor for that. Patients, as these cells remain active, if they have a hard time making their own antibodies because there's ongoing killing of the B lymphocytes, we can give patients what's called IVIG. It's an infusion of antibodies from healthy donors to help them avoid infection risk. We grade cytokine release syndrome by severity. If there's just a fever, that's grade 1. If there's more than that, if patients need some oxygen or if their blood pressure drops, it's grade 2. And then if grade 3 and 4 means that they might need to be seen in the ICU for a little bit for monitoring of their toxicities. For the neurotoxicity, there's a test that we do that's called the ICE score, which stands for immune cell encephalopathy. And encephalopathy just means like an abnormal state of the brain. So we ask patients if they know where they are, if they know what year it is. We ask them to name 3 objects like a clock or a watch or a pen. see if they can do, repeat back something you asked them to do. And then if they can just write a sentence that they choose at the beginning, many people just say that they're somewhat like they love their loved one. And then if they can count backwards from 100 by tens. So most people can do that. So if that's off, then we know that things are amiss and we intervene accordingly. Okay, so in looking at the approvals for second treatment of diffuse large B-cell lymphoma and for CAR T in general, there are 3 CAR T-cell products that are approved for diffuse large B-cell lymphoma in the third line and 2 that are approved in the second line. Of those that are approved in the second line, 1 is approved just if patients have relapsed within 12 months, and the other one, called LBCL, is if they've relapsed in 12 months or if they are not eligible for a stem cell transplant. And my plug is that approval came from a trial that we ran here at LDS Hospital as part of Intermountain Health. So I was telling you that CAR T cells beat transplant. This was the studies from 1995. That's why the figures don't look so good. They look old school. Of looking that patients were more likely to survive their treatment if they were transplanted versus if they were not transplanted. However, for patients who are not transplant or patients who need a transplant, if they relapse in less than a year, that's demonstrated by the red box down at the bottom there. That bottom survival is patients who received R-CHOP and then relapse at less than a year. Their long-term survival is about 10%, which looks like many metastatic terrible cancers, and it really, we needed to do a better job. So looking in there were 3 CAR T products that were trialed against transplant. And in those trials, patients received 2 to 3 cycles of chemotherapy, which is usually 6 to 9 weeks of chemo. And then if the chemo was working, they were able to go to a stem cell transplant. So patients were mostly randomized to either to try to get chemo and then a stem cell transplant, or they were randomized to just receive CAR T cell therapy immediately. In that trial, patients who received CAR T cell therapy were more likely to be alive, as demonstrated here, than if they received standard of care and trying to get to a stem cell transplant. That's impressive because if the stem cell transplant didn't work, many of those patients received CAR T cell therapy, or if they couldn't get to a stem cell transplant, they received CAR T cell therapy anyway. So just getting early CAR T cell would look to be even better than maybe trying something else and then getting a CAR T cell later. This is what's called the event-free survival. Pretty much, do patients stay in remission or not? And again, a huge advantage for CAR T. This is another trial using the other approved product called LBCL. This is the overall survival curve. Looks very similar to this one. And this is the event-free survival curve. Again, looks very similar to this one. So we think of both the CAR T products as being pretty equivalent. It would be nice to have a trial to compare them, and we're trying to do that. I'm part of a group that submitted a grant to try to do just that, so we can see if one is better than the other. As it stands now, they look to be pretty similar. This was the third CAR T product, and there are a lot of reasons why it didn't do as well, but it is not approved as a second treatment because it did not beat the standard of care on the trial. So in looking for options in the second line, about 80% or so of patients will have a response to CAR T cell therapy, and 60 to 65% of those patients will have a normal looking PET scan. And then if you look out at 4 years, 55% of patients with one CAR T product were alive, and with the other one called LBCL, 63% of them are alive. There are other treatments that are available in the second line that are novel agents. Tafasitamab, which is an antibody with lenalidomide, which is a pill that you take, and they had good response rates, but they didn't test it until later in patients who had relapsed early, and in those patients it did not work very well. So for patients who have late relapses, we can use tafasitamab with lenalidomide, or another treatment called bendamustine with rituximab and polatuzumab. So I want to talk about bispecific antibodies and show you what they look like. This is a cartoon, but basically this is an antibody with 2 arms. One arm is bringing together the T cell, the other arm is bringing together the tumor cell, and then helping the T cell, the immune cell, to kill the tumor cell. And then it's attaching on other cells that can help as well in this process of cell destruction. Looks like for some patients that achieve good responses, they can have responses that are long lasting. If you can see some patients out to even 4 years are still in remission after they receive a bispecific antibody, but not every patient responds. So you have 40% of patients who have a complete response, and then half of those patients have relapsed by 2 years. So you're really looking at more like 20% at 2 years, and it falls off from there. So there's still a lot to be done with these, but they can certainly be helpful. They have been tested in clinical trials in the second line, combining them with chemotherapy versus chemotherapy alone, and it does look like they are of benefit. So this is approved in what are called the NCCN guidelines, which it's not formally FDA approved, but an expert group of oncologists around the country from the top cancer centers has deemed this a recommendation if a patient is not able to get CAR T-cell therapy. Okay, so we have about 10 minutes before questions. So in looking at the third line and beyond for diffuse large B-cell lymphoma, we call this the bad old days. As bad as the second line treatments were, where I showed you those curves really dipped off. This is very similar, where patients have a 10% or less survival if they have had 2 prior treatments with diffuse large B-cell lymphoma and then relapse again. When you look at box C, you have over 300 patients, and you have 291 who did not respond, and you have only 18 who went into a complete remission. It's really abysmal in terms of outcomes. So this is why we need a CAR T-cell therapy. This is why we need bispecific antibodies. This is why we need ongoing research and trials into even improving upon the CAR T-cells and the bispecifics that we already have. So in the third line is kind of where bispecifics have made the most splash thus far. There are 2 bispecific antibodies that are approved. One is called glofitamab. It is an IV. It's a 4-hour infusion. It's given every 3 weeks. And then in clinical trials, it was given for a year and then stopped. The other one is called epcoritamab. It is a subcutaneous, so it's an injection into the skin. It's given so the difference is it's not IV, it's not 4 hours. You come in and get the shot, but you have to come in weekly for 12 weeks, and then every other week till you're 9 months out, and then you go to every month. And in the clinical trial for epcoritamab, patients did not stop treatment. They continued until they had a progression event. So patients could be on it for years. This is looking at 4 bispecifics. What we've learned thus far is that for patients who have lower amounts of disease, it tends to work a lot better than for patients who have a large amount of disease. So, one of our goals is trying to see, is there anything we can do to try to lower the amount of tumor before we give a bispecific if possible, or try to treat early, because those patients tend to have better outcomes. Sometimes you don't have that choice, but if we're able to do that, maybe with radiation or something, we like to try to minimize that disease burden. Again, just looking at patients can have responses that can be long lasting, even though it's in a minority of patients with these bispecific antibodies by themselves. I really do feel that the future of these treatments is in combining them with chemotherapy, with other regimens. Like I showed you the bispecific epcoritamab with R-CHOP at the beginning, really getting patients to almost 100% response rates. The combination with other treatments is probably where they do the best, rather than just by themselves as a single therapy. So looking at a couple of other therapies that can be used in the second and third line setting, this is looking at an antibody called loncastuximab. Is the picture here? It's an antibody that has like a chemotherapy payload attached to it, and it's in this graphic. It's internalized into the cell, and then once it gets in there, it drops off its chemo locally. So instead of having to deliver chemo all throughout the body and dealing with the side effects that come with that, such as neuropathy or hair falling out or nausea, vomiting, diarrhea, these therapies can be delivered locally and then decrease the total amount of side effects a patient may have. We talked about the tafasitamab drug. That's an antibody that attaches to B cells, and then the immunomodulatory pill called lenalidomide. And then there's an old chemo that comes from derived from nitrogen mustard gas called bendamustine, which isn't as toxic as that sounds. And then rituximab, which is a very common antibody used in R-CHOP. And then that polatuzumab drug that I showed you at the beginning that has been combined with, for use as a first therapy. It can be used later in combination with these other drugs. And it's a monoclonal antibody, which we call MABs, which just means all of the antibodies look the same. They're like one from one clone. And it attaches to a protein on the outside of cells called CD79B that's on B lymphocytes. This is a big graph. It's not there for you to have to go, oh my gosh, what's there? But looking that patients tend to have the highest response rates with CAR T-cell therapy, then bispecifics, then some of the other treatments. The toxicity is highest with CAR T-cell therapy for what we call cytokine release syndrome, or the neurologic toxicity, with a big chunk of patients getting cytokine release syndrome, and depending on the CAR T product, either a majority or a significant minority of patients having the confusion pieces that are almost universally reversible, but can scare loved ones for a while patients are trying to recover. Then looking at how long these tend to last, what the survivals look like. Again, the survivals are best for CAR T-cell, and then the bispecifics, and then some of the other therapies. So again, in my own clinical practice, I try to think CAR T-cell therapy first. If there's a reason I cannot give CAR T-cell therapy, which usually has to do with patients living far away and not being able to travel for the CAR T-cell therapy, or not having a loved one who can accompany them and help deal with some of the toxicity, then we think about bispecifics. And if they can't get bispecifics, we think about some of the other options. Lastly, I want to talk about some of the things that are coming down the research pipeline that I'm excited about. One of them is called an allogeneic. That means from someone else's gene pool. So that those are CAR T cells that come from a healthy donor rather than the patient's own cells. The advantage is those can be really healthy. Patients who have either had chemo or have cancer, their immune system's not normal. So can we do a better job if we get cells from a donor? However, the problem is those cells are foreign, so the immune system, our own immune system, is going to try to kill those off. They don't tend to last for much longer than 30 to 45 days thus far. But could make it much easier to get them, and their toxicity profile has looked better thus far than some of the autologous or self-derived CAR T cells. So trying to both see, after you've had other CAR T therapy, can we rescue patients with the second CAR that's from a healthy donor? And then there are trials looking to see at the end of R-CHOP, if you have a good looking PET scan, but we can still detect cancer DNA in your blood, is giving one of these less toxic, easier to access CAR T cell therapies able to kill off that little bit that's in your blood and help you avoid a full-fledged relapse. There are new CAR T products. I talked about the one that was just in the New England Journal published today. And then looking at ones that target two targets instead of one. We have trials for that open here at LDS Hospital, looking at new CAR T products, both allogeneic and these new autologous ones. And then trying to see if we can get, right now it takes anywhere between 2 to 4 weeks to manufacture CAR T cells. Can we get that manufacturing time down to 7 days or less? And then can we have safer CAR T cells? So better CAR T cells that are better to kill cancer. And then also, can we have CAR T cells that are less likely to cause bad toxicity? And then, can we continue to combine bispecific antibodies with other therapies to kind of maximize, or get synergy between 2 or 3 or even 4 different treatments together? So just to talk about, receiving lymphoma treatment at Intermountain Health, we have more than 10 oncologists who specialize specifically in lymphoma and other blood cancers. I'm just one of them. We have a dedicated blood cancer clinic here at LDS Hospital. And then we have, again, specialists in St. George and specialists at Intermountain Medical Center in Murray who specialize in lymphoma. And then we also have, a weekly, we call them hematologic tumor boards, where both Intermountain oncologists and then oncologists who are in private practice anywhere in the state of Utah or even in the Intermountain region. We've had people join from Las Vegas, from Montana, and from Idaho to help us, to ask for help with their patients. So they're able to contact us ahead of time. We get the patient's slides so we can look at the pathology, with a dedicated blood cancer pathologist. We look at the scans with a specialized radiologist, and then we have those of us who focus on treating blood cancers there to provide second opinions. So the patient doesn't have to travel all the way here. They don't have to, wait weeks and weeks for an answer. We hold these meetings every Tuesday, and work to really give the best care possible to patients regardless of where they live. If you don't live right next to a lymphoma specialist, we want to bring that expertise to where patients are. So we offer this service every week for oncologists throughout the Intermountain region. Lastly, our clinical trial footprint. So we have more than 30 oncology trials at Intermountain Health across all phases of research, phase 1, 2, and 3. So that's first in human trials, and then kind of establishing efficacy in phase 2, and then comparing it in a randomized fashion to standard of care in phase 3. You can contact us at phase1trials@imail.org if you have questions about the trial offerings that we have. Our goal as a clinical trial program, or research program, I guess in general, is to first think about what are the things what are the questions we need to answer, and then where can we find clinical trial opportunities that will allow us to answer those questions and help our patients to get access to the most promising cutting edge treatments. And then we want to bring those to Intermountain Health. I did my oncology training at the Dana-Farber Cancer Institute and Massachusetts General Hospital in Boston. And I watched people fly in from all over the world to get on, cutting edge clinical trials. And while the physicians there are smart, and they are very smart people, it's really about access, right? That's where the drugs were. That's where the therapies were. And so when I came to Intermountain Health 6 years ago, it was a priority for me to provide access to the very best trials possible here in the state of Utah and in the Intermountain West, so that people can get it where they live and they don't have to uproot their lives, travel thousands of miles from home for a therapy that hopefully they could get much closer to where they are. So anyway, that's our philosophy, and we're happy to partner with HealthTree and other organizations in the community to really advance cancer care and help educate patients. So I appreciate your time and listening, and I'm happy to answer any questions that people may have.
Thank you so much for that wonderful presentation, Dr. Hunter. So yes, it's now time for the discussion part of today's webinars. So if you have any questions about today's topic, you can drop them in the chat and we will go through those. So the first question we have is, are there certain factors that make patients more likely to relapse and need additional lines of therapy?
Yes, absolutely there are. Some of those risk factors are the stage of the patient's cancer. So lymphoma is different than other cancers in that, if you have a stage 4 breast cancer or colon cancer or pancreas cancer, oftentimes those patients, we think of their diseases oftentimes being unable to be cured. That's not the case with lymphoma. We still can cure the disease, but the likelihood goes down a little bit. So the stage of disease is important. Age is important to some degree. It's not super determinant, but it does play a role. But it's probably a surrogate for just how in shape people are. I've had plenty of 80-year-olds who can run circles around me, and they tend to do just fine with these treatments. So age is important, but it's really about function more than like the actual chronologic age. Then also some of the mutations that are present within the cancer cells, not mutations that you're born with, but or that you had your whole life, but mutations that are in these cancer cells. There are some mutations that are that are insensitive to chemotherapy. Chemotherapy just doesn't work very well. Like these double hit lymphomas where you have mutations in two of the major like two genes that really regulate growth, and then this also regulate the ability of the cell to just undergo self-destruction. So the cancers are growing out of control and they can't turn themselves off. And so those are the higher risk cancer. So those are some of the main things. And then we're still learning more all the time about what are specific, biomarkers in the blood that can help predict response. But those are some of the main ones we have today.
Thank you for that answer. And then our next question is, could I get CAR T or bispecifics at the clinic I'm usually treated at, or will I need to travel to an academic center?
Yeah. We are trying to get bispecifics out to as many places as possible. So right now, you can, if you start sometimes you have to come to a place like Salt Lake to start the bispecific therapy, but then after the first month, you can go back and continue to receive it where you live. Um, at Intermountain Health right now, you can you can do your whole bispecific therapy in Billings, Montana, in Salt Lake City, and in St. George. We're soon to launch in Grand Junction, Colorado, and in Denver, in Provo, and in Ogden. So we continue to try to support patients, at least after the first month, getting it wherever their oncologist is. And I'm hopeful that by the end of the year, that throughout most of Utah and some of the major hubs in the Intermountain West, that patients will be able to receive all of their bispecific therapy close to home. For CAR T cell therapy, it takes a dedicated team, and it's toxic enough right now that you really need a team with experience. And so because of the volume of CAR T every year, we do about 50 CAR T cell therapies a year. We've just continued to do them in a dedicated fashion in Salt Lake. We are opening up remote blood collection facilities, though, where we can collect the CAR T cells closer to home. We already have the ability to do that in St. George. So for patients who are in Southern Utah or in Las Vegas, they can travel a lot shorter distance and just have them collected in St. George, and then only have to come to Salt Lake when it's time to put them in. And they have to stay here for a couple of weeks for monitoring, and then they can go back home. We're trying to shorten that time, though. We're working to see if it can be changed for how long patients have to stay at the center where their CAR T cells are treated, if we're able to give training and education to the referring oncologist. I'm hopeful that in the next 6 to 12 months, we'll only have to keep patients around for 2 weeks instead of 4. But right now, if patients, we are sending patients home early if they live within 2 hours of St. George, because that's part of our network, and we've trained that team for how to treat some of these toxicities. So for patients who are doing really, really well after 2 weeks, we're trying to see if we can send them back early.
Perfect. Thank you.
There's a question in the chat from Lila. Is it okay if I answer that question?
Yeah.
Okay. So Lila's saying, so first of all, Lila's saying she's 11 months in remission from her double hit. Congratulations. That is a wonderful thing. And that she lives very close to Barnes Jewish, or the Siteman Cancer Center in St. Louis. One of my very good friends from medical school is on faculty there, and I've visited several times. That's a wonderful, massive cancer center. What is your next line of treatment if needed? So I hope you never need it, first of all, and that you're done. But in general, if you were to relapse at less than a year, the standard of care is to get CAR T cell therapies we discussed. For patients who relapse at more than 12 months, then it would be typically, depending on the way in the balance, the standard of care has been stem cell transplant. If a person is deemed ineligible for stem cell transplant, then your FDA approval is for CAR T cell therapy in that instance. But many patients who relapse will get CAR T cell therapy. If not, consider a stem cell transplant, which is 2 to 3 cycles of chemotherapy, and then a few weeks in the hospital for the transplant part of it. And then if disease were to come back after a transplant, then it's CAR T. So that could change, though. There's a lot of research going into seeing, even though I do transplant for a living, it's a brutal treatment. And so we're trying to figure out ways that we can have therapies that will beat transplant. But the problem is transplant for people who are late relapsers at more than a year still works pretty well. So that's been what we've used.
Thank you for that answer. And yes, congratulations on remission, Lila. Thank you for sharing that with us. And thank you, Dr. Hunter, for answering her question. And then another question is, how do doctors determine which treatments are best for patients at a certain time?
Yeah, so even though I know a lot of things, I'm certainly not God, and I'm not the person who needs to dictate what happens. I really see my role, and my colleagues do too. We are guides. So we have a lot of knowledge, and we share that knowledge, and we might have an opinion. And if we have an opinion, we will share that opinion. But we really want to be able to help a patient to feel empowered that they're part of this decision-making process. Talk about risks, benefits, pros, cons, and kind of try to come to a consensus of what makes the most sense. So not every patient will receive the same therapy in the same situation, because we're really trying to better determine, what's the right treatment for that person based on their goals, and based on the risks and that they're willing to take. So we sit down together and kind of see what makes sense. If I think a therapy is too dangerous for a patient, I'm not going to let them. I'm not going to say, oh, let's do it. But sometimes there's a little bit of wiggle room in terms of which treatment should we use. There's multiple CAR T treatments. So do you use the one that's manufactured more quickly but is more toxic, or do you use the one that takes a little bit longer to manufacture but is on an average gentler? Like, what is the main, what's your goal in treating? So and then, do patients say, like, this idea of CAR T sounds really science fiction. I'd rather do, other things, or I'd try bispecific, or, oh, bispecific is like injections for a year, hard pass. It's just, so there's a lot of discussion to take place between me as the oncologist and the patient and their family to figure out, what's the right answer. There are some people who just say, you know what, doc, I'm here to see you. What do you think? I'll do whatever. And so, and there are some people who really want to play an active role in making the decision. So I try to just really, be a source of information, and then give an opinion, and then still, guide that process with the patient.
Thank you for that answer. And then I think the last question we'll probably have time for is it possible to try CAR T or bispecifics before chemotherapy, or will chemotherapy always be the first line treatment?
What a great question. There are clinical trials right now that are looking at CAR T cell therapy as the first treatment. We have one of those open here at Intermountain Health that we're enrolling patients on, and that's for patients who have higher risk lymphomas. So like a double hit, like Lila shared, for patients with double hit lymphoma, instead of dose adjusted R-EPOCH, can you go straight to CAR T? And do those patients do better or worse? And we don't know. If they do better, then by all means, wonderful, and we'll move on. And if they don't, then we'll save CAR T for later. But we're trying to answer that question. I think some of the issues are that right now, because CAR T cells have to be manufactured for every patient individually, you can't just go and grab them off the shelf. It's a pretty labor intensive process. It's also a very expensive process. CAR T cell therapies cost many hundreds of thousands of dollars, and so the health system might blow up if every patient was eligible for CAR T. And if so, then we got to figure out a way to pay for it. But as it stands right now, they are not being used in the front line. We're going to see if they are able to be used in the front line. I think time will tell. There may be only a subset of patients for which it makes sense to undergo CAR T as the first therapy. I do think that if we project out 2 to 3 years from now, we are going to be using bispecific antibodies in combination with R-CHOP or similar chemotherapy as the first treatment. Probably more likely to be doing that than CAR T. But if we find the right CAR T that works amazingly, I think a lot of people like the idea of no chemotherapy, a one and done treatment. Like, I go in for my one thing and then I move on, rather than having to go through many, many cycles of chemotherapy, losing your hair, which is a horrible invasion of privacy. Everyone knows something's up. So I look forward to the day when we think of chemotherapy as bloodletting. It was this weird thing that people did way back when, before they knew better. So I hope that day comes, and that we can just use immune therapies alone.
Absolutely. Thank you. That will definitely be exciting to see what happens with CAR T and bispecifics in the future. And thank you so much for answering all of these questions and for your informative presentation. This has been so wonderful.
And no problem. My pleasure.
And before we go, I just wanted to quickly highlight a few more of our upcoming events. On May 20th, we have a webinar about how exercise can impact your recovery as a lymphoma patient. On the 21st, we have a webinar about all things clinical trials. And then on June 3rd, we have a bi-monthly blood cancer financial Q&A. We have a lot more exciting events in the works, so stay tuned. The link to sign up for any of these events and many others will be sent out in the follow-up email. We also have a number of upcoming in-person events. Connect to Cures allows you to connect with other patients, learn from doctors, and discover resources in your area to help you navigate your cancer. So if you're interested in attending any of these events, the QR code to register is on the screen. Before we wrap up, I just want to give a huge thank you again to Dr. Hunter for his amazing presentation, and thank you to all of you in attendance for being part of our lymphoma community. Your support means so much, and we're so grateful to have you here. I've included my email on this slide, so please don't hesitate to reach out if you have any questions. I look forward to seeing you at another webinar soon.